Good afternoon, everyone, and welcome to this webinar, How to Guide Medicare Enrollment for Older Adults, Part 2. Earlier in June, we had Part 1 of this webinar series looking at enrollment in Medicare, particularly geared to older adults who are approaching or will soon approach age 65 for enrollment in Medicare. This workshop webinar is being sponsored by AIDS United and ANAC, the Association for Nurses in AIDS Care. We have our presenters, Lisa Liu and Christine Long, and following their presentation, we will have a panel with Gilbert Ramirez, Malcolm Reed, and Ann Kalachan. As I said, two of our hosts for this webinar are AIDS United and the Association for Nurses in AIDS Care, ANAC. And to welcome us from AIDS United, I'll turn to Drew Gibson. Drew?
Thanks so much, Ronald. It's great to see so many folks on this call. We have an amazing presentation and panel set up for today. For those who are not familiar with AIDS United, we are a 501c3 based in Washington, D.C., but serving organizations across the country and dedicated to ending the HIV, viral hepatitis, and overdose epidemics in the U.S., and with a firm commitment on addressing the unique needs of people growing old and aging with HIV. Really excited to be here and can't wait for a lively discussion. I'll pass it back over to Ronald.
Thank you, Drew. And welcoming us from ANAC is Sheila Tumulty. Sheila?
Thank you, Ronald. We're really happy to be here and just thrilled to be co-hosting this part 2 with AIDS United. And I know you're in for a wonderful webinar. I know we're anxious to get to the webinar, so I'm just going to briefly say that the Association of Nurses in AIDS Care was founded in 1987, and we are a membership organization. We have national reach with a network of local chapters throughout the country and increasingly a global presence. But I do want to let you all know that we are not just a nursing membership organization. We welcome members from many different disciplines and students as well. You can see at the bottom of the slide our mission, and that is really our guiding principle. It breaks down to two main things. We foster the professional development of nurses and others, and we, mostly through our advocacy work, promote the health and welfare and rights of people living with HIV around the world. Next slide, please. So the last thing I really want to say today is that you are quite welcome, and we would love if you wanted to join us at our annual conference, which this year is just before Halloween, so I imagine that will be quite interesting, in New Orleans. Other than that, I know this will be a wonderful conference, and I'll turn it back to you, Ronald.
Thank you, Sheila. Next slide. Here are our learning objectives for today's webinar, and after the webinar, we are hopeful that you, the participants, will be able to discuss the pros and cons of choosing between original Part A and Part B and Medicare Advantage plans. In the first webinar, Christine and Lisa went over the overall process of enrolling in Medicare, and on this webinar, we will be diving a little deeper into parts B and C and the enrollment steps and challenges to those steps. So we are hopeful that you will be able to describe those basic steps and identify any challenges and opportunities in enrolling in Medicare from our panel discussion. Next slide. A few housekeeping items. If you have questions, we want to gather those questions. So please put questions in the Q&A box, and you can put them in the chat, but please, we would prefer if you can put any questions in the Q&A box so that we can monitor them for the panel discussion. And with that, I will segue and turn it over to our two presenters, Lisa Liu and Christine Long. Lisa?
Thanks so much, Ronald, and hi, everyone. We're really excited to be with you all today. I'm Lisa Liu. I'm a senior consultant at JSI and the senior technical advisor for the ACE-TA Center, and I'm joined by Christine Long, who's a consultant at JSI and the research and policy associate at the ACE-TA Center. Next slide. Next slide. So JSI's primary mission is to improve the health and systems of care for underserved populations worldwide, and this includes people with HIV and those who experience risk for HIV and related syndemics. JSI implements a diverse portfolio of projects across the US and values the lived experience and expertise of our staff living with HIV, staff of color, and people over the age of 50, and LGBTQ staff. The ACE-TA Center is one of our many projects that aims to help improve the quality of life for people with HIV. And so through ACE, we help build the capacity of the Ryan White HIV/AIDS program community to navigate the changing healthcare landscape and to help people with HIV access and use their health coverage to ultimately improve their health outcomes and their quality of life. Specifically, we support Ryan White grantees to engage, enroll, and retain clients in Medicare, Medicaid, and individual health insurance options. We also aim to build organizational health insurance literacy, thereby improving clients' capacity to use the healthcare system and to communicate with clients about how to stay enrolled and use health coverage. So we do this all by developing and disseminating best practices and supporting resources, and by providing technical assistance and training through national and localized activities. Next slide. So today we're going to talk about choosing between enrolling in original Medicare or Medicare Advantage. We'll also give you an overview of Medigap supplemental insurance and discuss enrolling in Medicare Part D or prescription drug coverage. Next slide. So to be eligible to enroll in Medicare, an individual must be a US citizen or a legal resident for at least 5 years, with some exceptions. There are 3 primary ways that people with HIV can qualify for Medicare. So being at least 65 years old, and so this would also be referred to as aging into Medicare. Other ways include being under 65 with a qualifying disability or having end-stage renal disease at any age. So CMS has a calculator that you can use to determine Medicare eligibility, and we'll chat out that link now. Next slide. So there are 3 parts to Medicare. The first part is Medicare Part A, which is hospital coverage, and that's on the far left on this slide. Part A covers inpatient hospital care, surgery, lab tests, skilled nursing facility care, hospice care, and home health care. So throughout the presentation, we'll use the H icon to represent Part A. Medicare Part B, which is in the middle box, includes medical coverage for services from doctors and other healthcare providers. I like to think of this as kind of your traditional medical coverage. So this includes outpatient care, preventive services, home health care. It also covers medications administered by a physician and durable medical equipment. So for Medicare Part B, we'll use the plus icon to represent Part B throughout the presentation. And then finally, on the far right, Medicare Part D provides coverage for outpatient prescription drugs, including HIV antiretroviral medications. And we'll talk more about each of these parts throughout the presentation. And we will use the medication bottle that's on the far right of the screen to represent Part D throughout. So even though there are multiple parts to Medicare, there are only 2 options to get coverage, and that's through original Medicare and Medicare Advantage. And Christine will talk about these in just a moment. Next slide. So you may have heard that sometimes you don't have to pay a premium for Part A, otherwise known as premium-free Part A. So in order to qualify for premium-free Part A without paying a monthly premium, you must have at least 40 quarters of Social Security work credits. So you can earn work credits by working in a job and paying Social Security taxes. And work credits are based on an individual's total annual wages or self-employment income. So you can earn 1 credit every quarter, which is 3 months, for a maximum of 4 credits per year. So 40 credits equals about 10 years worth of work. So these credits do not have to be earned consecutively either. So if you don't have enough credits by the time you turn 65, you can still enroll in Medicare Part A, but you may have to pay a premium for Part A coverage. And the premium amount varies depending on how many credits you have so far. It's also possible for you to continue working past 65 in order to earn the 40 credits needed for premium-free Part A. So we'll chat out a link now for more information about work credits. And now I will hand it over to Christine to talk about the difference in coverage between Original Medicare and Medicare Advantage.
Thank you so much, Liesl. Let's go on to the next slide. Alrighty, so as Liesl has said, there are two ways that you can get Medicare coverage, either through Original Medicare or Medicare Advantage. So I'm going to start us off by talking about Original Medicare first, which is also known as Traditional Medicare. So those two terms are kind of interchangeable. So Original Medicare includes Part A hospital coverage and Part B medical coverage. And the icons on the bottom left of this slide show that hospital coverage, which is the H, and medical coverage, which is the plus, are included together. Original Medicare does not include Part D prescription drug coverage, which has to be purchased separately if you need it. You'll see the pill bottle icon on the bottom left, which represents prescription coverage, has a dashed line around it, which indicates that it's optional. Now, in terms of coverage, Original Medicare allows you to see any healthcare provider across the US who accepts Medicare. You do not need to choose a primary care doctor, and you generally do not need a referral to see a specialist. So basically, you have access to a nationwide network. So in most cases, you can go and see any doctor, provider, hospital, or healthcare facility that is enrolled in Medicare. Original Medicare is also administered by the federal government. And what this means is that enrollment, coverage, and costs are determined by the federal government. So Original Medicare is going to look and cost the same amount, no matter which state you live in. Next slide. Now, if you have Original Medicare, there are some coverage gaps that you should be aware of, specifically deductibles and co-insurance. So if you're not familiar with these terms, basically a deductible is the dollar amount that you're responsible for paying when receiving covered healthcare services before your insurance plan starts to pay. And a co-insurance is a specific percentage of costs that you're responsible for paying per service after you've paid your deductible. So for Medicare Part A, this deductible is based on a 90-day benefit period. That means that the deductible can be applied up to 4 times a year. And you'll have to pay that deductible before your Medicare Part A coverage kicks in. And even after you've met the deductible, you could still face additional charges for long-term hospitalizations, skilled nursing care, and blood products. Now, for Medicare Part B, the deductible is based on an annual benefit period. But after you've met that deductible, Medicare will only pay for 80% of all approved charges. So you'll be responsible for the remaining 20% of the cost, which is the co-insurance that I was talking about. Now, depending on the cost of the specific service, 20% can be quite a lot of money, right? So, for example, if you're receiving a covered service that costs $1,000 and you've already paid your deductible for the year, Medicare Part B will only pay 80%, which is $800, and you would still be on the hook for the remaining 20%, which is $200. Next slide. So to help cover some of these gaps in Original Medicare, let's talk about Medicare supplemental insurance plans. These are also called Medigap plans. So these are optional plans that are intended to help you with those remaining costs of Medicare Part A and B coverage, like copays and the deductibles and the co-insurance that I talked about on the previous slide. So Medigap plans, these are sold by private insurance companies, but their coverage and their benefits are standardized by state and federal law. There are 10 different types of Medigap plans offered in most states, and these plans have letters in their name. So, for example, you might see Medigap Plan A, Medigap Plan F, Medigap Plan K, etc. And these standards are intended to help you, the consumer, to be able to compare Medigap plans that are sold by different insurance companies. They also have to be clearly identified to consumers as Medicare supplemental insurance, so that there's hopefully no confusion between original Medicare, Medigap plans, and Medicare Advantage plans, which I will be talking about in a few minutes. Now, you must have original Medicare, meaning Medicare Part A and Medicare Part B, in order to enroll in a Medigap plan. It's also important to know that Medigap plans do not include prescription drug coverage. So they're not going to help out with any copays, deductibles, or coinsurance related to prescription drug coverage. If you have original Medicare and you still need drug coverage, that has to be purchased separately. And Lisa will talk more about that in a few slides. We'll also chat out a link now that explains the basics of Medigap plans. Next slide. Thank you. So now let's take a look at some of the costs that are associated with these Medigap plans. So if you choose to buy one of these plans, you're going to have to pay a monthly premium for that coverage, which varies by insurer and plan type and where you live. As a point of reference, monthly Medigap premiums can really range anywhere from under $100 to over $1,000. And this is in addition to your Medicare Part A premium, if you have one, and your Medicare Part B premium. Now, for Ryan White clients in particular, your state's AIDS Drug Assistance Program, or ADAP, might be able to help you with paying that monthly Medigap premium. And as a general rule of thumb, usually the more expensive the plan is, the greater the benefits. However, Medigap policies generally do not cover things like long-term care, vision, or dental. And you might still have some out-of-pocket costs, such as deductibles, if the Medigap plan that you choose is not as comprehensive as you need it to be based on your unique needs and how frequently you access healthcare. But despite these limitations, Medigap plans might still be a good option for people who have more complex medical needs or people who travel during the year and anticipate needing to see a provider outside of the country. And we'll chat out a link now to a tool that can help you find and compare Medigap policies. Next slide. And next slide. So now let's talk about Medicare Advantage. So Medicare Advantage plans are plans that bundle Medicare Part A hospital coverage, Medicare Part B medical coverage, and in most cases, Medicare Part D prescription drug coverage. So you'll see that the icons on the bottom left of the slide indicate that these three parts are bundled together, and we'll use this teal plus icon to reference Medicare Advantage as a whole. Medicare Advantage is also known as Medicare Part C, so those terms are interchangeable as well. Advantage plans may or may not have a monthly premium. So as another point of reference, this year in 2023, the average cost of a Medicare Advantage plan premium was $18, but many of these plans have $0 premiums, which can be very attractive. For Ryan White clients, ADAP can help you pay your Medicare Advantage premium if you have one, but this premium is on top of your monthly Medicare Part B premium. Now, in addition to bundling hospital, medical, and prescription drug coverage, Medicare Advantage plans may also offer extra benefits that original Medicare does not, such as vision, dental, hearing, and wellness programs like gym memberships. Medicare Advantage plans are also starting to offer more extra benefits than they have in the past, like transportation to doctor's visits, for example. And you also won't need and will not be able to purchase a supplemental Medigap plan if you have Medicare Advantage. And also in the majority of cases, you won't need to purchase separate prescription drug coverage either. Now, unlike original Medicare Advantage plans are administered by private insurance companies that contract with the federal government. These plans are generally either an HMO or a PPO plan with a specific network of preferred providers. So if you have Medicare Advantage, you might need to get some services approved ahead of time, and you might need to get a referral to see a specialist. Next slide. So again, it's important to note that Medicare Advantage plans have pros and cons just like any other plan, and they may not be right for everyone. So for example, Advantage plans are not always the best choice for people with HIV because they usually have more limited provider networks. So this might make it harder for someone with complex conditions to continue seeing their existing providers who might not all be in the same network. And this is actually why most Ryan White programs recommend that their clients enroll in original Medicare, although this decision really depends on the Medicare Advantage market in your area and what your individual healthcare needs are. On the other hand, in some cases, Medicare Advantage can be a good option for people with less complex medical needs and those who don't travel out of state often or don't need to see out-of-network providers. Keep in mind also that copays and coinsurance can sometimes be higher for certain services and lower for other services under Medicare Advantage compared to original Medicare. And if you anticipate needing higher levels of care, such as acute inpatient services or intensive outpatient services, those costs can really start to add up. But the silver lining here is that there is a limit on yearly out-of-pocket costs. So I also just want to emphasize again that Medicare Advantage plan design, coverage costs, and availability will vary widely depending on what state you live in. So you should always consider your own healthcare needs and your budget when you're comparing Advantage plans. And we'll chat out a link to the Medicare plan comparison tool, which can help you do that. So this slide is just a recap slide. So as I've said before, there are two ways you can get Medicare, either original Medicare or Medicare Advantage. So if you look on the left side of this table, you'll see that original Medicare does include Part A, hospital insurance, and Part B, medical insurance. It does not include Part D, prescription drug coverage, which you can purchase separately. It does have coverage gaps and out-of-pocket costs, but you can choose to purchase a separate Medicare supplemental insurance plan or a Medigap plan to help you cover those costs. And original Medicare is administered by the federal government, which means that Part A and B enrollment, coverage, and costs look the same no matter what state you live in. And then Medicare Advantage on the right side of the table shows you that it is a single plan that bundles Part A and B, more often than not also includes Part D. Medicare Advantage plans also offer extra benefits that original Medicare doesn't and can have lower out-of-pocket costs for some services. There can be a monthly premium on top of the monthly Part A and B premium, but there's a yearly limit on out-of-pocket costs for covered services. They're administered by private insurance companies, so their provider networks and their costs will vary widely from state to state. So basically, there are a lot of pros and cons to weigh here, but we are going to chat out a detailed comparison table that can help you make an informed decision. And just lastly, if you are a Ryan White client, no matter how you choose to get your Medicare coverage, just know that the Ryan White program, including ADAP, may help pay in full or in part for Medicare and or Medigap premiums, deductibles, and co-payments. So with that, I'm going to pass it back over to Liesl. Thank you.
Thanks, Christine. So now let's take a deeper dive into Medicare Part D prescription drug coverage. So as Christine discussed, there are two ways to get Medicare prescription drug coverage. It's either by purchasing an optional Medicare Part D prescription drug coverage plan after enrolling in original Medicare, which is Parts A and B, or by enrolling in a Medicare Advantage plan that bundles the prescription drug coverage along with Part A and B hospital and medical coverage. So all Medicare prescription drug plans must provide a standard level of coverage set by Medicare, but they may offer different combinations of coverage and cost sharing. The Medicare drug plans also may differ in prescription drugs they cover, how much individuals have to pay, and which pharmacies you can use. So here are three key facts about prescription drug coverage. All Medicare prescription drug plans are required to cover all or nearly all the drugs in the 6 protected drug classes, including antiretroviral treatments for HIV. HIV drugs are required to be covered without any utilization management, such as prior authorization or step therapy. However, there are some Part D restrictions for non-HIV medications, including medication not on formulary and quantity limit issues. We found that often providers can generally work with a Part D plan insurance carrier to request a prior authorization or exception that overrides these restrictions to accessing some of the non-HIV medications. Next slide. So original Medicare enrollees only need to have a Medicare Part A or Part B at minimum to purchase a Part D plan, but you should enroll in both Part A and Part B when you first become eligible. Unless, of course, you have employer-sponsored coverage that allows you to defer enrollment without incurring a penalty. And we went into a lot of detail on this during the June webinar, so please reference that recording for more details on employer-sponsored coverage and Medicare. Part D premiums may be expensive, so it's important to find out if you're eligible for the federal Extra Help program, which helps people with limited income and resources to pay for some or all of your Medicare prescription drug program costs, like premiums, deductibles, and coinsurance. There are 2 levels of assistance, full and partial. And that's important because starting in January 2024, so in just about 6 months, the 2 levels of assistance will be eliminated, and anyone with incomes at or below 150% of the federal poverty level will get full Extra Help benefits. So this will expand the Extra Help program benefits to many more people. If you are not eligible for Extra Help, you may have a monthly premium for your Part D plan, but most, if not all, ADAP programs can pay this premium for people who are active in the Ryan White program. And so you may have heard about, next slide, you may have heard about the Medicare donut hole or coverage gap for prescription drug coverage. And this refers to the gap when an individual's initial Medicare prescription drug coverage has ended, but they don't yet qualify for catastrophic coverage. So on this slide here, you can see that an individual enters the donut hole when their total drug costs, including what they have paid and what their plan has paid for prescription drugs, reaches a certain amount called the initial coverage limit. So that's in the second box from the left. So when a person goes into the donut hole, the amount they pay for prescription drugs will be higher until you've met the limit for true out-of-pocket costs, also known as TROOP. So the TROOP limit is represented by that circle. Once you meet the TROOP limit, your plan's catastrophic coverage threshold kicks in. And from then on, you'll pay a significantly lower cost for the remainder of the year. And then the plan resets again the following year. So it's important to note that both the initial coverage limit and the true out-of-pocket costs or TROOP limit change every year. And you can check on Medicare.gov for what the updated numbers are for each year. I also note that ADAP expenditures for people with Medicare Part D coverage count towards their true out-of-pocket costs. So this helps you reach your catastrophic coverage level faster. So if you do get assistance through the Ryan White program, I encourage you to check with your local ADAP about how they can help you pay for the drug coverage while you're in the coverage gap. Next slide. And so that wraps up our dive into Medicare Part D. And I just want to share some tools and resources that can help you enroll in Medicare coverage. So the ACTA Center has a resource designed specifically for consumers called the ABCDs of Medicare coverage. And this is a brief plain language tool that describes the different parts of Medicare and includes most of the information that we just went over. It talks about the difference between original Medicare and Medicare Advantage. And you can print this out to read on your own or take it into your provider's office, or if you're meeting with a case manager or SHIP counselor to talk about your options for Medicare coverage. So you can find all of our Medicare tools at targethiv.org/ACE/Medicare. And we also have a collection of consumer-facing tools for different types of health coverage, and we're chatting out the links to those now. And you can find out more about the ACTA Center at targethiv.org/ACE. On the next, and you can email us if you have any questions. Feel free to email us at actacenter@jsi.com. We're happy to help you. And thank you all so much. I'll hand it back over to Ronald.
Thank you, Lisa, and thank you, Christine, for that presentation. If you have questions, please use the Q&A box to enter your questions, and we will try to get to as many questions as possible during our discussion period. And for that, next slide, I'd like to bring in our panelists, Gilbert Ramirez, who is a case manager at the Desert AIDS Project in Palm Springs, California. Malcolm Reed, who is a Medicare beneficiary and also works at and head of policy at Thrive SS Atlanta. And Ann Calichan, who is a SHIP counselor in Massachusetts. And remaining will be Christine and Lisa also during the panel discussion. But to you, Gilbert, Malcolm, Ann, that presentation was excellent, but it underscored for me as a person who is in Part A, but not yet in Parts B and C, some of the challenges of dealing with traditional Medicare, choosing a Medicare Advantage plan, Medigap, can be overwhelming. From your experience, what have been some of the challenges that potential and new enrollees face? And Malcolm, I'll pick on you to start from your perspective as a Medicaid beneficiary. What have you experienced, or what have you seen as some of the challenges in enrolling?
Thank you, Ronald, and thank you for this presentation. So my challenges were 1, confusion, and 2, expense. The confusing part is that even though you can go to Medicare.gov and get an understanding of Part A and Part B, when you're trying to choose between Medigap, Medicare supplemental plans, Advantage plans, you then are in the private sector market. And you start, once you look for a plan, all of a sudden you get bombarded with calls, right? Everybody's trying to sell their plan and everybody's telling you how their plans are better. You will even get a very kind person calling you and saying, I can help you navigate through all of this. But what they're telling you is, I'm going to navigate you towards my plan, whether it be a supplemental plan or a Part D plan. And then once you pick the plan, that's when the sticker shock starts, right? Because, and it's even in this presentation, it says Medicare Advantage plans, Medicare Part C includes, I should say, Part A and Part B. So when somebody says it includes it, I'm thinking, okay, I'm going to pay one premium, but that's not the case. You're going to pay a premium for your Part C, and you're going to pay the premium for Part B. So you have to factor that in. And then as a person living with HIV who does not qualify for Ryan White, because, I'm over the income limit for Ryan White, then when I get to Part D and find out that my HIV drugs are Tier 5 drugs, and with a Tier 5 drug, you're paying 33% of the cost, right? So I am on a drug called Dovato from ViiV, and my monthly charge before I hit the catastrophic limit is $975 a month. So for the month of January, February, and March, I would be paying $935. I am also married to a man living with HIV, so he's paying the same thing. So our family cost is $1,800 a month plus our premiums. So the cost itself is catastrophic. And so, like I said, it's the confusion and the financial. Now, there are some things that you can do. Most people coming from, in my situation, were coming from a plan where they got a copay card to help with their drug costs. Well, you can't use a copay card for Medicare, right? There's a law that prevents that. However, I urge people that if they are in my situation to reach out to your pharmaceutical company, the company that provides the HIV drugs that you're taking, Gilead, ViiV, Merck, whoever it is, and then see if they have a patient assistance plan. Because with a patient assistance plan, they will help you pay for your drugs, either partial or the full price of your drugs. And that's the only way that I'm getting through right now. Because like I said, I working here at Thrive as the policy advocacy director, I make too much money to qualify for Ryan White. And I wanted to do my nonprofit a favor. And so when I turned 65, I said, okay, let me go to Medicare, because that way Thrive doesn't have to cover my medical insurance, because as an older man, medical insurance on a company side is very expensive. But I found out that Medicare was very, very expensive for me. So I'll just say those things and then pass it on to the other panelists.
Thanks, Gilbert. Thanks, Malcolm. I want to turn to Gilbert now. Gilbert, what do you see as some of the challenges that people face from your experience as a case manager?
Well, I can, the challenges that that Malcolm was talking about, that's a difficult one when you're over income for Ryan White services, because Ryan White services do take care of a lot of those co-pays and co-insurances. Most of the clients here at DAP Health, I know it's a Desert AIDS project, but we are now DAP Health, so we've changed our name here in Palm Springs. I'll just kind of give you a background of DAP. We were founded in 1984 by a group of community volunteers in the face of the AIDS crisis. And DAP Health has been the Coachella Valley's primary non-for-profit resource for those living with, affected by, or at risk for HIV or AIDS. We are now a full-fledged FQHC. We provide primary care, HIV care, Hep C care, dental, behavioral health, and social services. I'm a medical case manager, so all of my clients are HIV positive. Most of my clients are Medicare age. We do a lot of ADAP here. We actually have an ADAP office here, and we have 2 ADAP employees that work here that we work with often. ADAP in itself is kind of complicated, and I think a lot of the challenges there is just making sure that they keep up to date with their recertifications. They've changed it, so now you only have to recertify on your birthday once a year rather than twice. I think some of the, like he was saying earlier, Malcolm was saying earlier, some of the challenges is not knowing what plans to pick, what plans will be covered with ADAP, not knowing who to reach out to for assistance. We have some amazing Medicare agents that we refer our clients out to. I think one of the most important things is find somebody that you trust and understands ADAP, understands HIV medications, are familiar with what people who are living with HIV have to go through and have to pay for. An agent who understands that can help. That's not biased as to their plan or their their particular, what they're particularly trying to sell. I think that's important.
Thank you, Gilbert. And as a SHIP counselor, I'm going to guess that you've seen a lot of challenges along the way. Could you talk about your experience in seeing the challenges that people face and how to deal with them?
Sure. So I just want to mention I am a SHIP counselor, which means I went through a special training in this state of Massachusetts to help people navigate Medicare enrollment. I work for an organization called Access Health MA that runs the Massachusetts HIV Drug Assistance Program. So we are an ADAP. We are sort of helping clients who meet the eligibility for our program cover whatever Medicare health insurance premiums meet our criteria to be covered. So sort of understanding, working with a SHIP counselor who has some knowledge, if you're eligible for an ADAP in your state, who has some knowledge and understanding of how that HSHAP can help you cover some or all of your Medicare premiums is important. And also sort of understanding how that ADAP program helps you to cover your medication copays. So clearly for somebody in Malcolm's situation who doesn't meet the income eligibility for his state ADAP, his situation is more complicated, and it does sound like you made very smart choices. I don't know whether or not you reached out to the SHIP program in your state, but sometimes SHIP can be a resource for helping you find sort of those copay assistance programs that might help you with your medication copays if you don't meet the income eligibility for your state ADAP. You know, it is such a, Medicare is complicated for everybody, and certainly more complicated for people living with HIV who are taking medications where if they are faced with paying the copays for those medications, that is sort of one of the biggest hurdles as people age into Medicare, I'd say. You know, maybe then choosing between original Medicare, a supplement plan, Medicare Advantage plan, where you're going to be dealing with out-of-pocket costs associated with medical care you get, becomes a little bit less of a challenge than that drug coverage piece, which is huge. So I have a lot more to say, but I'm sure I'll leave it at that for now, and we'll circle back.
Thank you for that information, though, Ann. I will check that out. I think I went through all of that, but I just got to go back and look because it was just, my head was spinning.
And we often always throw out acronyms and use acronyms and don't always spell them out. Could you say what SHIP is? So
SHIP is the state health insurance program. The state in which I'm in, Massachusetts, I am referred to as a SHINE counselor, serving the healthcare needs of everybody. So, you know, there are a lot of complicated acronyms, but every state in the United States, and I'm gonna let Liesl and Christine take this other thing, because Puerto Rico, there are some other, you know, there are other sort of territories, US territories, is required to have a program that gives free, unbiased counseling to people who are Medicare eligible and the families who are helping them navigate this complicated enrollment.
Thank you. Also want to say that we will be sharing the slides, and also there's a lot of links that have been put into the chat, and we will make sure that everyone has access and gets those links, those important information additions that have been added by Christine and Liesl in the chat box. And one of the questions that have come up, and I'll sort of ask Christine and Liesl to join in looking at this question, is a lot has been talked about the cost and drug costs in particular, and copays and deductibles, and meeting all of those costs. A question has been raised as to how will the Inflation Reduction Act that was passed earlier this year, last year by Congress, how will that impact or change out-of-pocket costs? And does that have any effect on the donut hole? Christine or Liesl, if you can start, and if any of the panelists can weigh in on what has been done via the Inflation Reduction Act to address out-of-pocket costs.
Liesl, I'm happy to start us off, and you can fill in the blanks if you want. So, based on what we've been reading about the Inflation Reduction Act, it's really going to go a long way to making sure that folks are paying less out of pocket. So folks with Medicare Part D in particular. So, just some highlights in 2024, the donut hole is going to get a little bit smaller, and it has been getting a little bit smaller year after year since 2020, actually. The 5% coinsurance requirement, like when folks are within that donut hole in 2024, is going to be eliminated. And Medicare is going to pay a little bit more of total drug costs than before. And then in 2025, I believe the donut hole itself is going to be pretty much eliminated. And there's going to be a $2,000 limit on out-of-pocket drug costs. In the Q&A box, I did chat out 2 links to some more detailed articles for folks who are interested in digging a little bit deeper into those specific provisions in the Inflation Reduction Act. But the short answer is basically it's going to do a lot to help folks with those high out-of-pocket costs. So Liesl, I'm not sure if you want to jump in or if anyone else has other things to add.
I just reiterate the point I made earlier about the extra help programs. That's another part of the Inflation Reduction Act that's bringing about a change in January for the extra help program. So that will be available to more people than it's currently available to, given the changes in the limits.
Thank you, Christina and Liesl. And Malcolm and Gilbert, what do you think people or clients and people seeking to know about Medicare and getting enrolled, do you think they know about these changes and what's newly available via the Inflation Reduction Act and the kinds of impact that it will have on costs? Is the word out around these changes, to your perspective?
No, go ahead, Gilbert. I'll let you go.
I mean, unless they're really researching or have access to, if they're HIV positive, have access to case management. Most you can find case managers, I think, most anywhere. But if you unless you're really looking for it, I don't think it's really available. I have a lot of people that come in or give me calls often, and people who are already enrolled in Medicare confused because they're getting calls from people about, they're trying to sell me this. Am I supposed to do this? I'm not sure if I'm supposed to do this. I don't know if I should ignore it or if they're just trying to sell me something. So I do get that in. I just bring me what you've got, bring me, and usually it's just a flyer or something. And I refer to our experienced Medicare agents that we trust, or I'll even call them myself to get information. No, not unless they're really looking for it, or they have somebody who's really, really kind of educated on what's going on. I usually refer to people I know can help if I don't know the answer to that. But no, I don't think it's readily available.
And I agree, Gilbert. I myself am an advocate. I work in this field. And when I first came over to Medicare, I mean, I was amazed with what I did not know and what I found out on the fly. And like I said, a lot of it was the confusion that is added when you are bombarded with calls to what Gilbert said. You're receiving stuff in the mail, you're receiving phone calls. My former employer has a relationship with United Healthcare, who sells a Medicare Advantage plan. So when they called me, I was like, oh, okay, this is an AT&T plan. Yeah, blah, blah, blah. Excuse me, I shouldn't have said the name, but anyway, I was like, oh, this is great. And I found out that it's I'm locked in right now, but it's not the best plan. So I definitely encourage people to see someone like Gilbert or Ann, if you have that availability in your community, because it's incredibly confusing. And that was before the Inflation Reduction Act. And so the Inflation Reduction Act changed a lot of it, and you can Google and look and everything else. But whenever you Google something, and now even with AI, the answers are in legalese. When someone asks the question, what does the Inflation Reduction Act do, I kind of put it into the new Bing AI chat, and I got back this paragraph, and I was like, what does that mean? So you really need to talk to people who have the experience and have gone through the process and understand exactly what the changes are. I mean, that's what I'm going to do, so that when I make sure that if people come to me or come to our organization, we're able to give out the correct information.
Thanks, Gilbert, and thanks, Malcolm. And do you have anything to add to that about the impact of the Inflation Reduction Act?
Yeah, I mean, it's not huge, but understanding what you hear. So I recently worked with a client who had done some research on his own, and part of the Inflation Reduction Act that rolled out in this calendar year was a reduction in the cost of the copay cost for diabetes medications, that it had to have a cap of $35 on it. And somehow this client, in contacting Medicare to sort of understand how his drug coverage what it would look like, somehow misunderstood and thought that was the maximum copay he would pay for any medication through Medicare drug coverage. And Medicare drug coverage looked great to him compared to the drug coverage he was offered through his employer-sponsored plan. And so, again, partnering with somebody who can help you understand and dissect this information. And I wanted to just also plug, Medicare and Social Security do not call you unless you've asked them to call you. They don't reach out and try to sell you plans. They don't tell you they have something better to offer you. So I think both Malcolm and Gilbert sort of touched upon this. Once you're aging into Medicare, there are, people who are going to outreach to you and try to make it seem like they're selling you the best plan. Via phone, via text, via email. You're going to see the advertisements on TV where they're going to give you money back in your Social Security. Take all of that with a grain of salt and find somebody who can help you navigate what's best for you.
Thank you, Ann. And that touches on a question about educational sessions. And I know we're almost at time, but I would urge everyone to look at, in your community, organizations like Thrive, like the Desert AIDS Project in Palm Springs, for whatever educational efforts that may be offered in your community, as well as, of course, contacting your state's SHIP counselor. I want to thank everyone who participated in this webinar, and realizing again that this was part 2. So again, thanks to Christine and Liesl and Ann for their participation in the first webinar. And to really thank all of you who signed in and signed on to and are participating in this webinar and have raised some of the questions. This will be an ongoing effort on all of our parts, as those of us who are approaching 65 years of age and living with HIV deal with enrollment in webinar. I want to thank our colleagues at AIDS United and the Association for Nurses Care for all of their work and assistance in bringing us this webinar today. And again, to thank our panelists, Gilbert, Malcolm, and Ann, for your expertise and sharing your knowledge and your perspective with all of us on the webinar today. And that, I'll see if there's any last minute words. Gilbert.
Yeah, I just wanted to remind people too that if you do qualify for Medicaid, you can have Medicaid with here in California, it's Medi-Cal, so you can have Medi-Medi. So if you already are insured through Medi-Cal, you can move into a plan that includes Medi-Cal as a secondary to pick up that 20%. Okay, so that's really important. So know if you qualify for EDAP, know if you qualify for Medi-Cal when you are receiving Medicare benefits.
And SHIP counselors can help you make that determination. So I'll just throw that out there. Thank you.
Thank you. Yes. Realizing we have probably many states represented on this call and through our participants. So it's really important to contact your local SHIP counselor and get the kind of assistance and help. They're there to help you. You can tap into those resources. Again, I want to thank everyone for being here today, dealing with Medicare, dealing with the challenges of enrollment can be a daunting process, but as I think has been demonstrated on this webinar today, there are people out there who know what you're going through, know what the process is, and can help you. Please utilize all of the resources in your community to face the challenges, but the importance of enrolling in Medicare. We want to wish everyone a good afternoon, and this concludes our webinar, and thank you very much for being with us today. And thank you again to our presenters and our panelists.